Okay, the next chapter will be chapter 31, Opioid Agonists and Antagonists. So these are used more for moderate to severe pain. Remember that agonists are going to attach to the receptor and produce a response, the same response as what it's supposed to be. Antagonist, it's going to bind to one of the receptors, which is the response, and then binds to another receptor to prevent that response. And then an antagonist is going to attach to a receptor site and prevent the response that we want. So it's going to attach to it and prevent. So for instance, one of them would be Narcan for an opioid overdose. You're going to use Narcan to stop the response of the opioid. Okay, opioid agonists to begin with are morphine, fentanyl, meroperidine, methadone, codeine, your oxycodone, which is your Percocet, your Oxycontin, Percodan, and then Indocet, and then hydromorphone, which is your Dilaudid. Okay, so the action of these medications, they activation of the mu receptors, produces the anesthesia, respiratory depression, euphoria, sedation, and then can lead to physical dependence. Activation of the kappa receptors produces the analgesia, sedation, and decrease that GI motility. Because remember, with opioids or any type of narcotic, the one thing that we got to watch is constipation with these medications. Therapeutic use is relief of moderate to severe pain, sedation, reduction of bowel motility, and then a cough suppressant. And that's more, they use codeine for your cough suppressant. Complications that can occur with these, respiratory depression is definitely at the top of the list. We need to make sure we monitor vital signs if they are in an acute or long-term setting. Withhold the opioids if the respirations are less than what? Make sure if they're less than 12, then you need to withhold it and notify the provider, because more than likely you're probably going to end up giving them some Narcan to reverse it. Have naloxone and resuscitation equipment available. And then discourage the use of other opioids and with other CNS depressants, because you're just going to increase that side effect of the respiratory depression. So any barbiturates, benzodiazepines, or alcohol would be considered. Don't be taking or using while taking an opioid. Constipation, you need to give them a stimulant laxative, so like bisacodyl, to help keep them from becoming constipated, or a stool softener, such as docosate sodium, which is your cholase. Have them, any client that has end-stage disorders such as cancer or AIDS, and they're going to, and are opioid dependent, administer opioid and antagonist, methyl naltrexone, to help treat severe constipation. So once again, having them increase their fluids to 2 to 3 liters a day, increase their fiber and physical activity. So orthostatic hypotension is another complication. So assist them when getting up out of bed or out of a chair. Tell them if they start feeling lightheaded or dizzy that they need to sit down or lie down. So making sure that they change those positions slowly. And the reason that orthostatic hypotension occurs is because the dilation effect on the peripheral arterioles and veins. So any sudden movement and change in position is going to drop that blood pressure. So once again, what do we want to get on these people? We need a 3-way blood pressure, lying, sitting, and standing, at least once a day, if not twice a day, just to keep track. Urinary retention. We need to monitor I's and O's. Check the bladder for distension by palpating the lower abdomen at least every 4 to 6 hours. Medication, opioid, can suppress the awareness that the bladder is full. So then they're just retaining all that urine in there, which could also lead to a bladder infection if they just have urine sitting in their bladder all the time. You need to have your client at least urinate every 4 hours. And then the medications with the anticholinergic properties, remember, can worsen this manifestation because they have urinary retention as a side effect or a complication to these medications. So your tricyclic antidepressants, your antihistamines are going to doubly cause that problem. Okay, cough suppression. So the thing that we want to assess here is going to be auscultating the lungs for crackles. Remember, those are like Rice Krispies or crumpling a paper, going to be the sound. We need to have them coughing at regular intervals to help for fluid to set in and accumulate in the lung area to eventually develop pneumonia. Having them cough and then making them drink more. Having them drink more to help liquefy those secretions so they can cough them up more easily and get them out. Note color, how much. That way, if you need to get a hold of the doctor to send it off for culture and sensitivity to see if they need an antibiotic or anything, if it's a viral versus a bacteria. Then sedation, so avoiding any activities that are going to cause them to have to be alert. Biliary colic, avoid giving morphine. The people that have a history of biliary colic, we need to use apiridine, which is your Demerol. Biliary colic is when a patient is they have pain because they're trying to pass a gallstone, and then the duct becomes clogged or blocked. This comes and goes in a fairly regular pattern, so there's not an inconsistency. There's more of a consistent pattern to somebody who has biliary colic. And then the opioid overdose triad, this is coma, respiratory depression, and pinpoint pupils. We need to monitor vital signs, assist with providing mechanical ventilation, administer naloxone, the opioid antagonist, to reverse your respiratory depression and any other overdose manifestations. Contraindications are your biliary tract surgeries, prematurity, kidney failure. Precautions, respiratory disorders, infants, head injuries, older adults, pregnant or clients in labor, inflammatory bowel disease, enlarged prostate, hepatic or kidney disease. Interactions are going to be your CNS depressants, your anticholinergic agents, meperidine with MAOIs, antihistamine or antihypertensives, amphetamines, clonine, and morphone. Sorry. Nursing considerations, WILDA, so assessing pain, getting their vital signs, double check opioid dose, whether you double check it or have somebody check it with you. Naloxone and resuscitation equipment if their respiration's less than 12. If they are showing signs of respiratory depression, we need to be administering this medication. Do not increase the dose. Without consulting the physician. They need to make sure they're consulting their provider before they automatically just increase that. Cancer, they're going to be on a fixed schedule. Physical dependence, they need to taper off over 3 days to not just automatically stop. PCAs, which is your patient-controlled analgesic. You may have seen these in the acute care after surgery. The patient will never overdose themselves on this. It's set in there to the settings. So if they push it 100 times in an hour, they're only going to get a dose every 6 minutes. Is typically what they're usually set at. You can do nurse boluses with the PCAs, but then once again, that's only every 4 hours or whatever the doctor has written for. We can do first administration of a transdermal patch. It'll take several hours to achieve the therapeutic effect. So you may want to give them some pain medication on top of giving the transdermal patch. So just look at the time, the half-life of it, to where maybe you could just give an oral narcotic or opioid to help get that immediate pain relief before the patch actually kicks in. Because a lot of times with these medications, especially if we give an IV morphine, as you guys know, anything IV is going to be quick acting. So I have in the past, I have given the narcotic at the same time I've given IV pain medication, because the IV medication is going to be wore off before the oral medication kicks in. So hopefully by the time that the IV is wearing off, that the oral medicine will kick in and they'll get a longer period of time with pain relief. Okay, so your opioid agonists and antagonists. Your opioid agonist antagonists, so Nubain, Suboxone, these are going to act as antagonists on the mu receptors and agonists on the kappa receptors. Low potential for abuse, causing little euphoria, less respiratory depression, and less analgesia. They use this for moderate to severe pain and labor pain. Treatment of opioid dependence, that's your Suboxone. And then adjunct to the balance of anesthesia. Complications that can occur, your absence syndrome, which we've talked about this before. Cramping, hypertension, vomiting, fever, anxiety. This syndrome can result when there's a physical dependence on the opioid agonist and when they receive the medication. That is one thing big when you have somebody coming in for surgery. You want to ask history-wise, because you don't want to be giving them a med that could ultimately, that they've been addicted to before. And some of these have properties of those medications in them, the pain medications or anesthesia that they're going to be getting. So you want a good history of drug use, or just even patients that have been prescribed pain medication. Avoid giving these medications to clients who suspect opioid use. And then for the client, stop taking the opioid agonist, such as your morphine, before taking an agonist-antagonist medication. Then you have sedation and respiratory depression. So just having the naloxone, and then your recitation equipment, and then obviously monitor for your respiratory depression. So monitor their respirations more closely. Remember, less than 12 is considered, you need to do something about it. You need to take action. Dizziness, just tell them to use caution when standing up. Avoid driving and using heavy machinery till they know exactly how these medications are going to affect them. Monitor for a headache and check their level of consciousness. Make sure that that hasn't been altered. Precautions: anybody with a history of an MI, kidney or liver disease, respiratory depression, or head injury. And then physical dependence on opioids. Interactions are your CNS depressants, alcohol, opioid agonist. Nursing consideration: make sure you keep track of vital signs, especially the respirations. Naloxone and resuscitation equipment at bedside. Well, not the naloxone, but the resuscitation equipment, keep at bedside. Screen for opioid dependency. Prior to giving them any medications, do not increase dosages unless without consulting the provider. And then just remember to tell them to change position slowly to avoid the hypotension. Okay, then your opioid antagonist, which is your Narcan or naloxone, it's going to work against. It's an opioid antagonist, interferes with the action of the opioids by competing for the opioid receptors. It's going to knock it off those receptors so it can inhibit it. Therapeutic uses are going to be reversal of the effects of opioids if they're having, such as respiratory depression, and then reversal of respiratory depression in newborns. Complications, tachycardia, tachypnea. So we need to make sure we need to monitor EKGs, heart rhythm, so they need to be hooked up to a telemetry unit because they are at risk for ventricular tachycardia. And then also monitor their respiratory function. Are they able to breathe on their own? How fast? How slow? Just the characteristics you need to note. Once again, having resuscitative equipment at bedside, so your oxygen, and then it'd be available to administer. Once again, your absent syndrome, the cramping, the hypertension, the vomiting, reversal of anesthesia. Then it's contraindications and precautions, pregnancy risk category B. Nursing considerations, naloxone, it's a first rapid pass inactivation. So IV, IM, sub-Q, or intranasal, it's going to pass the liver, like we had talked, the first pass effect. Observe the withdrawal manifestations. A rapid infusion of naloxone, you got to watch for hypertension, tachycardia, nausea, and vomiting. The half-life of the opioid analgesia can exceed the half-life of naloxone, so 60 to 90 minutes. So you need to monitor them up to 2 hours after the use.